We were lucky in TZS because we had one PAS system. Now, a lot of acute trusts have lots of different departments. They have the benefit of fewer sites, but the disbenefit of many departments with their own systems. So data migration, you have to create what's called a unique key so you can join that in. What we also had is we had the old system available in read only, but we identified via the clinical routes again what was the key information that people needed to see on day one. And we migrated all of that. Now, what we did is in the old system, we converted all of the documents into PDFs so they were readable. And then what the system did was then turn that into searchable. So data that was unsearchable in the past suddenly became digital and you could search for it. And we also then categorized it. But what we did is we resisted the urge to have 50, 60 categories and we put them down into like 12 with maybe subcategories, because there's no point digitizing all this data and migrating it in if it's then not accessible and easy to use. What I would say is data migration is complicated, and if you're pulling from an old system, data quality will be questionable. So don't underestimate the length of time it takes that. Something that we did, and we were still migrating data, many months later on. But what we did is we prioritized the first 2 years recent, and then we would roll in the next 2 years and the next 2 years. So the focus being on the most recent information is really important. But in mental health and learning disabilities, that's not to say historical data is not important, but you want to make the clinicians need to make decision on the latest information. So make sure that is in first and have it clinically checked.
Yeah, brilliant. Thank you so much, Richard.
We created a platform, and the first because the EPR is a culture change and it's an ethos as well, and it's that the trust was faced with quite a lot of challenges around having a single care plan and a single safety plan, putting the patient at the centre of care and being collaborative in their care plan. The first few training courses that we released earlier was very much about what the ethos was and what the culture is that we're moving towards. It is very challenging. Hospitals are running at vacancies and sickness rates, and it's often it's challenging to fulfill positions and roles and things. So you've got to, what we did was very much online learning that people could dip in and dip out. Ideally, what we'd have liked is a system once it was earlier to play with, so you can go in there, because and we created videos as well. So I'm a person that likes visualization. Other people like to read the details. So we tried to supply both in such a way on this digital platform. And again, linking back to what I said previously, we put how-to guides and goal guidance into the system, because it'd be very unfair to ask a clinician who's coming to look after patients to learn a brand new system by watching a video once or whatever, and then remember it maybe 3 months later to do the job. So the first part was very much awareness, and the training online was very much of this is what's coming, and this is how it will work. For me, it's kind of like just giving some awareness of what's going on. Then it's making that online training available. And then if there were trends that maybe we're highlighting from practice, there would be messages to go back to say, don't do it like that, do it like this, and this is the reason for it. But I think training needs to be monitored ongoing and reflected and broken down into bits. So if you've got 10 minutes with a cup of tea, you can do a bit of section of that, but always in your mind that you don't just learn something at once. It's really you learn when you've got your hands on. So if you can make available an area, we were unable to do that you can play around with. We did get some people to do that, but that is one of the challenges. If you can do that, that's a really good approach. I don't know if you can manage everyone's expectations, and I think it's you're allowed to have high expectations. I think for me, it is a case of that transparency in the communication, like I've said before. And it's that feedback of when you, so if you've got your data and you've got those things, you can feedback what is happening, what the improvements are. But again, clinical engagement is absolutely crucial from the beginning, middle, and the end. But an EPR doesn't end, it just evolves. So I think maintaining a good clinical core of champions and experts and a good clinical team. Personally, for me, I would have a clinical, dedicated clinical team for the EPR. It's that important for me. And being able to feed back, and again, back to the big ears, small, big eyes, and listening to what's going on and feeding those back. Because sometimes the expectations are there and they have been met, but people are unaware of it because, like I say, communication is very challenging. So you have to, again, celebrating your wins by doing that. Potentially, you're also posting things which people say, oh, I didn't know that could happen. And again, maybe running events and things. But I think people's expectations change and are continuously there. So it is that continuous engagement that's really key to continue. Yeah. Oh, I would say, and there is one of the ladies on the team, she might be able to back me, that I would say that they very much do own it. I mean, I was very much told at certain times, it's not yours, it's ours. And one of the examples is I designed the EPR front end and it was all nice blues and greys, typical sort of IT. And then the clinicians looked at it and said, well, that's boring. So it had a complete facelift and it's got multicolors. And what we used, I think it's really important, it's something I learned from them, was the use of icons and colors and things. So everything to do with care plans was yellow. So the forms would be yellow things. So it's not, so then it's also for people that you can say, well, the yellow forms are care plans. So it was clinically driven. I mean, it did lead to some challenging conversations, and I'll be honest, I do miss some of that back and forth, but you're a team when you're doing this. So people have different things. I would absolutely say that, but that only works if you really do listen to your clinical team, and the organisation gives the space for the clinicals people to be involved. Again, I was very lucky. I had some very good clinical people that were engaged and were permanent on that. And there were times they were off and they were doing things and I had to play catch up. So I do really, I would honestly say that I think that for me is one of the things I did do well and was managed to get that clinical ownership.
Fantastic.
And that was really, really paid off. Well, like I say, when it's challenging at the end, and because there will be challenges on Go Live, there's no two ways about it.
Of course.